Hi everyone, my name is Emily Rossman and I had case study 87, which discusses folic acid deficiency anemia. Patient Walter Lewis, or WL, is an 80-year-old man who has come to the Veteran Administration Hospital for a routine checkup. The patient states that he has been feeling really lousy lately, he has no energy whatsoever, and is always cranky. The patient has a heavy medical history including type 2 diabetes, chronic obstructive pulmonary disease, or COPD, for approximately 11 years, a seizure disorder for 17 years, but he has not had a seizure for 3 years due to medications. Also, the patient has chronic stuffy noses, hypertension, hyperlipidemia, multiple deep vein thrombosis with chronic venous insufficiencies, as well as mild memory loss. In addition, the patient had prostate cancer, which he had his prostate removed, and he had a stroke as well as a hip fracture 7 years ago, and he unfortunately still has chronic lower back pain and right buttocks pain. The patient's father and brother died of the black lung disease, and one brother is still alive with hypertension and diabetes. His mother is still alive and appears healthy. Overall, the patient is pleasant, cooperative, and an oriented elderly man in no apparent distress. He does have some difficulty focusing and tends to ramble. He drinks alcohol heavily and has a long history of cigarette use of about 10 cigarettes a day. The patient is on several medications including docusate sodium, trimeterine, loratadine, cyclobenzaprine, acetaminophen, glipizide, HCTZ, pravastatin, warfarin sodium, ipratropium bromide, and phenytoin. Walter's vital signs show some abnormalities. His blood pressure is 130/85, which is high, but for his age it is normal. He has a BMI of 28.1, which means the patient is overweight. In addition, the patient has a mildly increased pulse rate of 110, however, the patient has tachycardia. Walter's skin appears normal with actinic keratosis and is pale. His head, ears, eyes, nose, and throat also appear regular, although the patient does wear glasses and he has a slightly pale conjunctiva and oral mucosa. In addition, the patient's neck, abdomen, extremities, rectal, and genital exams are normal for the patient's age. Walter's lung exam shows that he has decreased breathing sounds with drawn-out expiratory and inspiratory wheezes bilaterally. Other than the tachycardia, the patient's heart appears normal. The neurological exam shows that the patient has facial weaknesses due to the stroke. Otherwise, Walter's coordination and reflexes are normal for his age. Lastly, the laboratory blood test results show several clinical manifestations. The patient's glucose fasting, mean corpuscular volume, glycated hemoglobin, and international normalized ratio levels are high. Walter's hemoglobin, hematocrit, red blood cell, white blood cell, platelet, folate, alkaline phosphatase, and HDL levels are low. Likewise, the blood smear shows unequal red blood cell size. In conclusion, Walter Lewis is suffering from folic acid deficiency anemia. After this case study was written and posted, someone asked a really great question regarding folic acid deficiency anemia. John Doe from Grand Rapids, Michigan asked, why is it absolutely imperative to also measure the serum vitamin B12 concentration in a patient who is suspected of having folic acid deficiency anemia? Great question, John. The answer to your question is quite simple. Vitamin B12s are primarily done to help diagnose someone with folic acid deficiency anemia. They are also done to determine the cause of the anemia, whether it be malnutrition or malabsorption. They are usually ordered when large red blood cells and decreased hemoglobin levels are found in blood tests. That's all we have for questions today. Feel free to post more.